So the topic today is considerations for alcohol use disorder care across the life course. We're going to focus a little bit on older adults and youth and general adult population as a reference. Acknowledgements. These are similar to the other ECHO presentations, so I'm really not going to spend time going over them, but just wanted to mention disclosures for myself, no commercial interests, but I do want to note that I do work in a variety of somewhat specialized care settings and recognize that that context is slightly different from a primary care setting, but do see people and collaborate a lot with the family physicians. So have a pretty good idea of how things evolve in primary care. Disclosure of commercial support. Again, the ECHO program is a partnership with the government of BC and Doctors of BC, and I will receive an honorarium for presenting today. Mitigating bias. The presentation actually has already gone through process for review and ensuring that it's approved for accreditation. So these are the rather large learning objectives for today, so you'll really have to pay attention and read fast to fit them all in. But I think really overall the key goal is to just get a feel for some of the unique considerations in working with youth and with older adults who are experiencing troubles related to alcohol use, and looking at how we can address and begin to engage people in care. So this is quite a busy slide with lots of numbers, but I think most people are somewhat familiar with the lower risk drinking guidelines for adults of all ages. And I wanted to focus in then on older adult and youth guidelines. So the Canadian Coalition for Seniors Mental Health published a series of guidelines in last year that address alcohol, cannabis, opioids, and benzodiazepine use disorders in older adults. And these are part of the alcohol related guidelines that were included in there. And I was really glad to see these because they really give us a better sense of how we can coach people and engage them in conversations about, you know, what's happening with their use of alcohol. Many people are surprised to hear the numbers that are recommended. So for women age 65 and older, less than or equal to 1 standard drink per day, and for men, less than or equal to 2 standard drinks per day. In a week, for women, maximum 5 and 7 for men. And this includes non-drinking days. That those non-drinking days are really key to reduce the risk of developing tolerance and also reducing risk of habit formation. So when we look at youth, of course, I think we all recognize the risks to youth who are, you know, still in the midst of brain development. So exposure to alcohol can be really risky. And so if youth less than 19 are going to drink, the recommendation is that it's limited to 1 or 2 standard drinks per occasion and not more than 1 or 2 per week. And I think many of us would recognize that even that level is more risk than we'd ideally like to see. Youth aged 19 to 24, their recommendations are similar to adults of all ages, but again, recognizing that that's still a period of really rapid brain development. So this is a slide from the Canadian Tobacco, Alcohol and Drug Use review that was done in 2017. And, you know, one of the key things to highlight here, and so this is representing the respondents who were consuming alcohol and the proportion who were drinking at risk. And particularly here we see with the young adult group, really high rates of risky drinking. And so 28.9% for chronic risks and 22.7% for acute risks being things like MBAs and whatnot. So really, those are quite high numbers when you think of that being also still a very vulnerable time for people as far as developing socially and careers and school and whatnot. So something that we really need to pay attention to and try to address. This is an overall prevalence from Statistics Canada, the Community Health Survey, just looking at prevalence of high-risk drinking and alcohol use disorder. And the one thing I really want to highlight here is the numbers that we see for youth, but also for older adults, I really do believe are underestimates. And this could be partly by the sort of number of drinks that are being looked at as far as risk, but also we really know that in older adults, high-risk drinking and alcohol use disorder are really under-recognized. So I think these numbers really probably do underestimate. We're going to talk, just skimming through today, about the alcohol use disorder clinical pathway. And so touching on each of these sections as we go through, so I won't sort of go in detail about this slide. Screening. So generally speaking, screening for alcohol and other substance-related concerns really needs to happen regularly. And so a number of organizations have come out with recommendations saying yearly screening for all age groups. And I think that many people are now finding ways through EMRs and whatnot to remind themselves to do that. But it often comes up in situations where people are presenting with other concerns, and just being aware of what some of the adverse effects that can happen with alcohol can help you sort of clue into the fact that maybe there's something else contributing to their presenting problem. There's a number of screening tools available, and I think the key with any screening tool is that you've engaged the person in some form of, as they say in psychology, therapeutic alliance, or that you've got rapport developed before you start asking questions that can often be quite sensitive, and people often carry a lot of shame and guilt about drinking. And so making sure that you've engaged in a collaborative sort of goals or process of working towards well-being and health goals. Different screening tools have different sort of things that they identify. Everybody's familiar with the CAGE, and it's good because it's easy to remember, and we've all heard about it, but it does specifically look at alcohol use disorder and doesn't necessarily identify when people are running into problems with alcohol earlier on. So, but it's still helpful. AUD-C is the sort of concise version of the audit, and again is looking primarily at amounts over the past year and specifically day to day. The single alcohol screening question is really ideal, and I think this is the one in the BCCSU guideline that's sort of emphasized. And again, really it is looking at the lower risk drinking guidelines and getting a sense of where people fall in that range. So screening for youth it takes a little bit different approach, and one of the tools developed by the NIAAA is the screening tool that focuses first on asking about friends' use of alcohol and then asking the youth about their own use of alcohol. And that helps to, again, sort of get a sense not only of the social context that they're coming from, but also helps to, again, normalize the questions that you're asking about alcohol use. The CRAFT is also a good tool, and audit and AUD-C have also been validated for applicability in youth. Screening for older adults, again, recommendation generally is yearly screening, and often I think it fits in the situation where people present commonly with falls or trouble sleeping, or we often see problems with GERD or hypertension that's hard to treat. when we're seeing a sort of a picture of something that may be of concern, often, it's a good idea to check in about alcohol use as well. A number of good screening tools, again, that provide a foundation for your conversation, but often the actual scoring and the details aren't as important as opening the conversation to start to get a sense of what's happening for the individual. The SMAS-G is 10 items, so it's a bit long, but it can be provided to the person to complete before you meet with them, again, depending on the situation. The carrots focuses more on some of the risks specific to older adults, like interactions with medications and health concerns. So it's very good, but not very accessible. The SAMI was developed in Canada for home care workers to, again, open up those conversations about alcohol use. So, worth looking at, a number of different tools to get an idea of how you want to word your discussions and what key things to look for. Again, the highlights, the shoulds of screening are all we, I think, intuitively know. That the screening tool is only really going to be as good as the communication that you're having with your patient. So diagnosis is an interesting question, and I think one that can really be challenging in working with many people who are struggling with substances, including alcohol, but particularly more so, I think, at the sort of youth and older adult age groups. And, part of the challenge, again, is engaging people, but also some of the things that we, typically would recognize as concerns in adults may not be as applicable in other populations. And so looking at sort of DSM-5 criteria, for instance, so for youth, looking at, they may have not developed tolerance, they may not be experiencing withdrawal symptoms in the same way, and so can really have be experiencing more problems than we would typically recognize. But youth, even with mild alcohol use disorder, are really at high risk for, impact on brain development, drinking and driving, assault, injury, and alcohol poisoning, and development or progression of their substance use disorder. Older adults, again, DSM-5 criteria, there's a few limitations just in that many older adults, their occupational and social role obligations aren't as sort of structured, so it may not be as apparent if they're not meeting those. As well, with increasing sensitivity to effects of alcohol, older adults may not show the same degree of tolerance, and so we may not recognize that. A lot of times, older adults themselves, but also care providers, may attribute alcohol-related like withdrawal symptoms or complications to other conditions, and so it's harder to, again, identify alcohol use disorder. There's also a risk of false positives, both with older adults and with youth. But again, I think we have in the past erred on the side of missing really significant, people are having significant trouble related to alcohol use. So I think concern about the false positives is kind of lower down on the list of concerns. With older adults, it really requires a comprehensive geriatric assessment to get a good sense of what is happening. And as primary care providers, we're in a good role to be able to sort of know people over time and get a sense of what are some of those other pieces, so that that comprehensive assessment doesn't happen in one appointment. And even if it is the first time you're meeting the person, it doesn't have to happen all at once. Often the first appointment is about screening, get a sense of what's going on, maybe evaluate the really acute risks, but then plan for further follow-up to get a better sense of really what is happening. A key aspect of assessment, particularly relevant for older adults, is function and cognition. And again, these are things that, you know, typically because of, you know, changes in other physical health status and maybe psychiatric symptoms, certainly can have more impact. One of the things that is really helpful in work with older adults is, if they are open to it, having a loved one join and be able to participate and provide support and collateral is really helpful. So when we talk to people about alcohol use and go through sort of the initial screening questions about how much people are drinking, if we're seeing that they're drinking above the lower risk guidelines, but haven't really, it appears, developed an alcohol use disorder, then certainly a brief intervention is well established as an intervention that can improve outcomes. And this has been studied in youth as well as older adults. We have to adapt the messages that we include in that brief intervention depending on the person's situation, and sometimes maybe for youth, talking about, again, delaying drinking until they're, you know, legal age, and also harm reduction strategies, and, you know, across the age spectrum, of course, ensuring that people are drinking in a safe environment and trying to limit the drinks for youth to 1 or 2 per occasion. For older adults, brief intervention might focus on cognition, brain health, sleep, and general health, and often that's a way to sort of engage people's interest in considering changes to unhealthy drinking. So withdrawal management is something that really is important to keep in the back of our minds whenever we're seeing somebody who's talking about high-risk drinking, or, well, particularly alcohol use disorders, where we'll see the real risks with withdrawal. So I think most people are familiar with the pause, and I'm sure it's been talked about in other echo sessions, but it is, you know, fairly standard now in working with adults, but does have some limitations with youth and also with older adults. So it hasn't been validated for youth, but again, you know, a lot of sort of youth early on in substance use disorder are not going to have the same symptoms and withdrawal and whatnot. Now, if they are at risk of withdrawal, then definitely, you know, consulting an addiction specialist if you have any concerns, or typically the sort of adult pharmacotherapy would be sort of applied. So with older adults, with pause, the one thing I do find is that people really do have trouble recognizing withdrawal symptoms. And so it may have a severe tremor or, you know, sweats and that sort of thing that they aren't necessarily recognizing as significant withdrawal symptoms. So the pause still has applicability and still some utility, but often also with older adults, there may be underlying health conditions or cognitive changes or social isolation that really makes it very high risk for them to go through withdrawal in their home environment. The CCSMH guideline presented some good recommendations around alcohol tapering for older adults, and they outlined sort of a safe guideline of 1 standard drink every 3 days up to every 1 standard drink every 2 to 3 weeks, from, you know, a more aggressive to a more gradual tapering. And this can be helpful in situations where people just really aren't able to engage with the idea of inpatient alcohol withdrawal, or in the setting where it may not be available. Still, with that, it really does require a fair amount of structure and support. So, you know, has some limitations, but is something to consider if the individual is wanting to do that. Thiamine treatment parenterally for withdrawal is well established. We know that people at risk of withdrawal symptoms from alcohol really should be receiving thiamine. The oral supplementation isn't as well established as far as the amounts, or, do we need cofactors such as magnesium and that sort of thing. And we know that thiamine isn't as well absorbed if people are drinking. So I always err on the side of caution and recommend the higher dose of thiamine, 100 milligrams per day. And I think that is also in the BCCSU guideline, along with recommendations for all age groups for folate and B6. Oh, I didn't talk about, sorry, the CWA. There are, a few limitations I've run into with the CWA with older adults. And again, they may be experiencing a tremor from something else, or if their cognition is, is declining, may not be able to, answer questions about orientation and that sort of thing. And also just being able to self-report symptoms can be a concern. The recommendation generally has been for sure to use shorter acting benzodiazepines, but I do know that there's been recent discussion with Island Health about changing that particular recommendation for inpatient treatment of withdrawal. And I think really that, again, is just highlighting really the clinical scenario is so important, and there are unique considerations that may make other longer acting benzodiazepines the best choice. But generally speaking, the short acting benzodiazepines are better just because they're less likely buildup of metabolites and whatnot. So continuing care for older adults and youth for pharmacotherapy, we'll talk about here and maybe have some time in the discussion as well. So again, the BCCSU guideline has a great summary of medications for treatment of alcohol use disorder. In my work with older adults, I've found naltrexone to be a really, really useful medication and generally well tolerated. Of course, one of the things we really need to make sure and check about is whether people are being exposed to opioids, and Tylenol-1 particularly. Often people have accessed and don't realize that it's an opioid and can run into some trouble with it. Acamprosate also very helpful. The two sort of deciding factors, and I'll talk a little bit about youth in a second here, but with naltrexone, it's typically helpful for people who don't necessarily have an abstinence goal, but are interested in reducing alcohol consumption. And acamprosate tends to be more effective for people who have been abstinent for 4 or 5 days and who have a goal of abstinence. Now, having said that, again, depending on the clinical scenario, you may need to try one of the other medications depending on the other sort of considerations. We're talking, so this slide's mentioning some of the second line pharmacotherapies, and again, can be very effective in certain situations, but a little bit more limited when we're talking about older adults or youth. One of the things about topiramate actually that I didn't see in the BCCSU guideline that it's important to ask about is history of kidney stones, because they're also increased risk in alcohol use disorder and would be a reason to not prescribe topiramate. It also has both of these medications have a lot of cognitive side effects, so can be not as well tolerated by older adults. For youth, definitely consider first-line pharmacotherapies for youth that are struggling with moderate to severe alcohol use disorder. I have also prescribed some second line for older youth who are struggling with opioid use disorder as well. Topiramate is something that you may want to sort of consider. Again, that's off-label and it is second line. But in a unique situation, you might want to consider something. And of course, in a situation like that, do consult addiction medicine, prior to prescribing. And for youth, certainly would be a good idea as well. I think I've already sort of talked about these aspects with older adults. Again, start low, go slow. I often start at 12.5 of naltrexone and see how people tolerate it, and then gradually increase. Last but definitely not least is the psychosocial treatments. And again, as primary care providers, having a good foundation in motivational interviewing is really key and can, I think, be a real central piece to helping people with making positive changes. The other thing I will mention is the collaborative prescribing agreement for naltrexone and acamprosate. If you sign that, then people for whom you're prescribing those medications, it will be covered. Of course, there's other catches to that with their pharmacare coverage and Plan G and all that sort of thing. But one of the things it's signing that is it talks about also people needing to be engaged in treatment. And I really emphasize that if people are having that conversation with you about alcohol use and about making changes, that is treatment. That is, in fact, the key to many people's treatment, is that engagement in care. So I think having not to have hesitation if they aren't necessarily engaging with a really structured program, but as long as they're having some ongoing connection with care provider, then that covers it. So, and again, this is just a summary of different models for treatment. And I think most people are quite familiar with some of the community-based supports. I will also mention that Pathways right now is doing a revision of their addiction medicine resources. So hopefully those will be more accessible and will include a number of these. I'm going to do a really quick plug for Thrive, which is a caregiver support program through connected sort of with BCCSU as well, but we'll maybe share some of that resource a little bit later. And I think this is a really good slide to sort of finish on. And it's, again, just emphasizing the importance of adapting our approach when we're engaging youth in care. I think youth often are really, they're going through a developmental stage where engaging with sort of, supports other than their peers is really difficult. And so anything that we can do to break down those barriers will increase their engagement and their success in making healthy change. I think we've already talked about all those pieces. So, and my summary.